Good afternoon, everyone. Welcome to the Open Minds Executive Web Forum. My name is Christy Hoskinson, and I'm the General Manager for Open Minds Market Intelligence Services. And today, as part of our weekly Elite Member Only Executive Web Forum series, we're welcoming one of our Senior Associates, Sharon Hicks, to have a conversation around telehealth sustainability. Now, what is the role of hybrid telehealth / in-person in this next normal that we're living in? And we know it's going to be very challenging for regulators, insurance companies, and employers to reverse the rules, right, that supported the widespread use of telehealth during COVID-19 pandemic. It's still going on. And consumers and providers of these services have developed new models for connection over the past year. Moving back to full in-office, face-to-face treatment as the preferred method of service delivery is going to actually be difficult. So that's the big question. Are provider organizations ready for telehealth long-term? And Sharon's going to address this question today, as well as discuss a case study that speaks to the creation of a telehealth program focused in behavioral health, including what these programs look like, how to design them, and the necessary steps to take in this transition. So let me set the stage for what's going on today. Welcome to the session. I see that we have 5 live attendees. That's awesome. Your audio is going to be muted, but here's what's going to happen. Sharon's going to make this interactive. She is going to pause at certain times over the course of the hour to ask you some questions. And then you're also going to have the opportunity to ask her a question. And how do you do that? With GoToWebinar, there's a feature, and it usually shows up to the right of your screen, and you're going to see the word questions. If you hit that little triangle, you can go ahead and type in your question. So whether she's paused to ask the audience a question or you simply want to ask her a question, that is where you're going to insert your question at any point over the next hour. And we look forward to your participation. Let's definitely keep this interactive. Just so you know, the slides and the recording from Sharon's Executive Web Forum today will be available on the Open Minds website tomorrow. And with that, I'm going to close by introducing Sharon to you, and then she'll take it away. Sharon has over 30 years of experience in behavioral health, including having been a clinician, hospital administrator, chief information officer, and chief operating officer of a behavioral health managed care company. She has been working with healthcare technology, including data management, for almost her entire career. With that, Sharon, it is my pleasure to turn the floor over to you.
Thank you, Christy. Just making sure, is my sound okay for everybody?
Yes.
Okay,
perfect.
Great. So one thing I realized, which kind of horrified me, is that it's actually closer to 40 years because I got my first job as a inpatient clinical social worker on a children's psychiatric unit when I was only 23, and I'm 61. So, gosh. Okay, that said, that depressing thought over. I do want to make sure that everyone understands I'm happy to be interrupted. I'm happy to have people ask questions. This is a broad overview, and I've included a lot of information in the slides that we won't necessarily go over, but that I want you all to have when the slides get posted over the next couple of days. So with that said, as Christy introduced, we really have to think about what is the next normal look like? What does it look like when people get back to being able to go out, being able to come into services, and how is telehealth going to help fill that gap? Oh, sorry, I'm having mouse trouble. Okay. So, telehealth has been around for a long time, right? This is not 100% new. They've been talking about even remote surgery using robots. So, I mean, telehealth in general has been around for a while. It hasn't been very widely implemented, but the COVID pandemic supercharged everything. Medicare made lots of changes that allowed people to provide telehealth services even if they weren't in the same state. They actually allowed providers to forego the collection of self-pay. So there was a lot that happened, and the Interstate Compact was really big. There's a lot that happened that allowed people to expand to telehealth to take care of folks during the pandemic. Now that we're getting close to being at the end of year one of this pandemic, we're not 100% sure what's going to happen, but it's very clear that you can't put the toothpaste back in the tube. So now that everyone is used to teleservices, it's very unlikely that all the regulatory changes are going to be undone and go back, but some will. One study estimated 154% increase in telehealth during the last week in March 2020 compared with the same period in March 2019. And when you think about that, it's probably much bigger than that overall, because I don't think people at the end of March 2020 understood that we were going to be in this situation for a whole year. But it is very likely that the next stage of telehealth is going to be hybrid. The idea that we're going to be able to provide competent and effective services 100% remote as our primary model of care delivery it's unlikely. So everyone is now trying to figure out, well, what does that mean? And how do I keep my overall practice healthy? And what's the business use case for telehealth within my health system? So let's talk a little bit about some of the considerations. And again, what's interesting about the way that telehealth is happening right now is this slew of regulatory shifts made the barrier to creating a telehealth program much lower. So if some of those things change, many of the programs that are in place right now are going to have to retool because they're not going to meet all of the standards once the emergency has lifted. So one of the things that I think we don't talk enough about, because I'm a geek, is that the platform really has to meet the standards of federal and local requirements for data security. And I'm not sure that everything that people are using right now to stopgap is going to be able to do that. Staff must really clearly understand what's expected of them. And we'll talk a little bit more about that later. What's interesting is people got used to doing things online. So if your scheduling still requires that people call you to get an appointment, it's unlikely that you're going to be able to maintain that. This kind of distributed scheduling or online scheduling is going to become really mission critical. And then service documentation and billing is definitely going to be one of those areas where, again, as the regulations tighten back up, people are going to have to pay significant attention to. So the International Society for Telemedicine and eHealth, which I will not try to pronounce, commissioned a review of successful telehealth programs. And I'm going to go over their findings in the next set of slides. But one of the most interesting, I thought, was that you develop, along with the leadership team, a vision for your program. And you pay attention to what are the strategic and tactical objectives for the program, so that as you're developing your infrastructure, your documentation processes, your clinical scope of practice policies, you can make sure that you're staying with the goal, that everything is in line with your overarching goal. Let me stop here before we get into, these are the findings from that international group. Let me stop here and just ask if anyone is willing to talk with us a little bit about their experiences working in a telehealth program right now.
The groups, feel free to put some comments in the questions section. Again, that's in the little GoToWebinar app feature in the top right hand of your screen. You click on questions, and just go ahead and type in your comments that Sharon just asked.
And your comment might be, I don't want to talk to you.
And that's okay too. We'll see if anything shows up here in the next few moments.
I'll keep on going. So this, these are, again, these came from an international survey and were cited as the best practices for a sustainable telehealth, whether it's hybrid or 100% telehealth. Scope of practice was one that came up a lot. What are your supervision requirements? How do you offer supervision when you have the clinician on one end and the person receiving services on the other end? What's your documentation requirements? When I was a very young trainee social worker back in the Stone Ages, I had to write out everything that happened in the session so I could discuss with my supervisor what the family said. I was a child family therapist, what the family said, and then how I responded, and my supervision was very detailed in terms of process. When you're online, it's not always as easy to communicate what you think you're communicating. And so you have to really think about your supervision for all levels of your staff, not just the, non-licensed or not just the non-masters level. What are your emergency procedures? What happens if something happens while the person is on the line? And that could be anything from a clinical emergency to, one of your patients lives in Texas and they have no water and they have no power. Or one of your clinicians does. And so you have to have all of that. And then the implementation of evidence-based practice, I think, is really interesting because most of the fidelity studies were face-to-face. So what does it mean to have fidelity to the model of, let's say, trauma-focused CBT? And how do you make sure that you're sticking with that level of quality for your staff? Other issues that they brought up that I've seen in other pieces of literature, how do you make sure you follow all of your local, state, and national laws regarding written consent? For example, it's not uncommon for Medicaid to have a rule that says that when a person presents to receive service, they must sign something to indicate that they are the person getting service. So how do I do that if everything is electronic? How do I get people to sign a consent if I'm never going to see them in person? And what do I have to add to my consent form? And what do I have to add to my overall description of treatment so that the person understands the issues that are inherent in receiving their services remotely? And then one of the ones that I think is going to be really difficult is what's the financial implication, right? So when Medicare said, oh, you can relax all of your co-payment, co-insurance rules during the pandemic, that was all well and good, but what happens when that is relaxed and now I owe $20, which I would have paid at the front door when I came and signed in, but now I'm going to have to be billed. So is that going to increase your organization's days in accounts receivable? Is it going to increase your uncollectible rates? And so CFOs are going to have strong opinions about those questions. Cultural issues, including language. How much do you use your body language? You can tell I'm someone who speaks with my hands. How much of this translates as I'm trying to explain or discuss something that might be, touchy or sensitive? And then are there other cultural issues? My parents are in their 90s and try to attend a weekly Zoom with us and with my generation and our children. I've seen my mother's chin on Zoom, but I can't quite get her to understand how to show her whole face. And so there are going to be culture issues, age issues. And then there is an issue of privacy, which I do think people don't exactly know what to do with. And one of the issues with privacy is that as I'm sitting here talking to you, there are other people in my home who could be listening to this conversation. And so if I'm trying to actually have a therapy appointment, where do I go in my home so that my conversation is private? And in fact, we were doing a summit on child health, and one of the providers who was at the summit said that the children they're working with remotely are reporting to them when they're in person that they're not being as truthful because they're worried that their parents are listening. So when someone asks, and when was the last time you drank? The kid says, oh, I haven't drank, anything for a week. Drunken? Drank? I don't know. And so, it's because I'm worried that my mom is at the door listening in. So we have to think about all of those kinds of things. The next set of components that we should be paying attention to, obviously, is just the medical records documentation. So is this integrated with your existing information system? Are charge master records being created from this? Is the information entered going straight into the medical record? Are there any concerns about people storing data locally on their local machines and not having it go up to a server that has a lot of security associated with it? And then, of course, this same issue of informed consent, getting signatures, making sure that everybody understands what your rules are about recording sessions. And then one of the big issues is what is called in the IT world BYOD, which is bring your own device. When you have people bring their own device, meaning your staff, your ability to control the privacy and to assure the security is lessened because they can set their systems up to override some of your policy processes, which gets us to data security and data privacy. And I won't get into this too much, but one of the things that we're learning from the COVID pandemic is that we absolutely have a digital divide in this country. It is folks that have poverty as well as people who live in very rural areas. There are still very rural areas of this country that have no connectivity or very bad connectivity. And so we need to think as even just getting the staff availability to do telehealth, we need to be thinking about what part of that burden is going to be borne by the organization. And one very quick example of that, and I'd like to hear how some of your organizations are thinking about this, because I don't think there is a kind of consensus yet. One organization I know makes having high-speed internet at your home a condition of working for the agency. And another agency provides everybody with some kind of a monthly stipend that they're supposed to use to pay for their high-speed connectivity. So all of a sudden you get into this issue of, if my job requires me to have high-speed internet and I'm someone who lives in a disadvantaged area where high-speed internet may not be available, or I'm someone who lives out on a farm where the only thing I can get is, satellite-focused connectivity, and it's not going to be high speed. Are we really saying that group of people is no longer employable? So I'm interested to hear what, if anything, your organizations have done with that context of not just how you help the people who are getting services, but your staff who you expect to be able to staff cases.
Let's see. It looks like we have a question coming in. Thank you, Anne. We do monthly stipends and also provide laptops and wireless hotspots. So I guess it's not so much a question, but just contributing to the conversation.
No, that's great. And again, I think that model of assuring that if this is something you need to do your job, the organization provides it for you makes a lot more sense than having people, agree that they have to have some kind of high-speed internet just to get their job. But it is, it's a real issue. And again, in the Child Summit, one of the providers of remote services for children was saying that school districts gave out laptops, but they locked laptops down so that they could only be used for school. So when the clinical therapists, even the ABA workers or the people who would have been in the classroom were trying to connect with the child, they couldn't use the education laptop because it was locked down for anything except education. And so some of the families didn't have an extra computing device, and so children weren't able to get their services because of lack of a computing device, even though they had a laptop that was given to them by the school. So lots of different things to think about that no one really 100% has on their list until something happens. So obviously the clinic of the future is likely to be available both through a distributed model and an in-person setting. And I think has to be focused on access. I think, and I have another slide about this that just says access, access, access. But I think we have a lot of barriers to getting care that we need to think about how to reduce. And if we want people to feel comfortable getting our services, then the process of getting an appointment should feel familiar, but it doesn't necessarily feel that way now. So we have to be able to be flexible, and we're probably going to have people in service with us who are both doing some sessions in person and some sessions out of, remotely. And so we really need to be thinking about how does your electronic health record allow for that seamlessness of experience for the person getting services. So it feels the same to me. I'm filling out the same forms. I'm seeing the same stuff, regardless of whether I'm in an office or in my home. So let's stop there to see if anybody has any questions. And if not, we can go on to the next section.
Nothing yet at this time.
Okay. So let's go through some of the best practices that are being written about nationally and that people are discussing on the World Wide Web. So at the end of 2019, the American Medical Association estimated that $250 billion in Medicare could be shifted to distributed computing systems, or could be saved if we shifted to distributed computing systems post-pandemic. Whoops, I'm sorry, I'm having. Oh, here we go. Non-acute care, urgent care assessments, home visits, remote monitoring. They believe that these savings come from avoiding emergency room visits, avoiding healthcare office visits for all of the routine services, and even the health home services being able to be done in a virtual setting. They think that 2% of the outpatient volume could be shifted to the home setting with tech-enabled medication administration, or medical administration of services, rather. So I think this is really fascinating. I think this construct of being able to provide even things that are urgent, not emergent, but urgent, could really reduce the population of people going to emergency rooms. And imagine if I could dial into an urgent care center model that is run by my PCP and explain what's happening. And then the PCP could say, sounds like you have this. I'm gonna send you to your local lab to get a blood draw, or, oh no, I see what you have and this is definitely that. I'm gonna call it a prescription. That construct of just making things easy. So what is our corollary on the behavioral health side? What kinds of things could we have available for people when they feel like they're starting to potentially have a crisis and they're going to call the crisis service? Can that crisis service respond with a face-to-face interaction that allows the professional on the call to determine if something else is needed? And so I just think it's really interesting, and we have to figure out how to integrate it into our existing practice. I think when people think about telehealth services right now, they're mostly thinking about outpatient visits, right? I'm on the phone, you're on the phone, we're looking at each other, we're talking, I'm asking you, how does that make you feel? And that all makes sense. But what about the construct of having an intensive outpatient group where you had 5 or 6 people on the computer and you're basically running your group on the computer? Or what about the construct of, doing really, more intensive services where you might be online with your clinician multiple times during the day? So I think that the world is definitely moving and we have to move with it, but we get into the things that we need to make sure we have so that we don't lose our shirt and we don't have to close our programs because we haven't thought about these things. So obviously the first one is regulatory malpractice and legal. So will insurance companies increase your malpractice coverage because you have staff who are doing services remotely, and that will make the insurance company feel like you have less control, less supervision, less ability to intervene, less ability for someone to get up and go get help? And so you really, that is something that needs to be paid attention to. And then how carefully do you design scope of practice? So, if any of you ever worked in a hospital setting, there's a staff privileging construct. If the staff privileging group can show that, let's say I went to medical school, I graduated from medical school, I completed an internship, I completed a residency, I completed a fellowship, and I'm board certified in child psychiatry, then they say, okay, here are the things child psychiatrists can do. You are privileged to do those things. But we tend not to have that detailed level of privileging happening on the behavioral health side. For example, we don't necessarily say a certified alcohol counselor can do this, but a person with a master's degree and a license can do that. We do it very broadly, but we don't necessarily do it as, I don't know what the right word is, conscientiously or, as a hospital privileging office. And so we do have to think about how to build those relationships. So if I'm a family therapist, do I have to have a relationship with an advanced practice nurse who can prescribe? And if I'm that advanced practice nurse, what's my supervision relationship with the MD who's going to, make sure that I'm prescribing in a reasonable way? And if I'm a MD, what medical director is going to be looking at my standards of practice? So that whole scope of practice by person is going to be, I think, a function that we don't necessarily pay a ton of attention to, and hopefully our electronic health record clients are going to, or solutions are going to help us deal with some of those things. Informed consent practices. So, it's information sharing, but it's also the consent to treat and consent for specific environments. And so if my service is 100% remote, do I tape the person saying, tape, see how old I am? Do I digitally record the person saying, yes, it's okay to do that? And then is that stored in the medical record? So, like those are just issues we haven't really had to deal that much with during the pandemic, but we are going to be dealing with post-pandemic as we try to build this new normal. And then administrative and technology issues. So we have to make sure we have security. We have to make sure that clinicians understand. As an example, right now I'm doing this webinar. Everyone in my house could hear me. What if I were having a clinical session? That would be really inappropriate for my husband to be standing in the next room listening to me talk with somebody about their issues in a therapeutic setting. So, how do we know that our staff are abiding by our rules? That's going to become an issue. And then I told you I had this slide, so now you can see my slide. But access. We have to make things easy for people to schedule. We have to be welcoming. We have to make sure we can see people quickly. And that is something that as an overall market, healthcare has just not done a great job with. I had been having some problems with my hip, and I called my PCP to give me a referral to see an orthopedic surgeon who specializes in hips. And, by the time I was done and had an appointment, it was 3 or 4 days. The appointment was scheduled for 8 weeks out. So it's not just in behavioral health that we have this problem, but we do not have a wide open front door. We don't make it easy for people. And I don't know if anyone on the phone or on the call wants to, or the webinar or whatever the right words are, it feels comfortable sharing what they've done during the pandemic to make their organizations more accessible, to open their front doors a little bit wider.
A great question, Sharon, and I will definitely chime in if there is an answer to that. Yeah.
And there is still obviously resistance to overcome. People are worried. People don't trust technology. People are not 100% sure that even if I say I'm not recording it, they're like somehow secretly thinking I am recording. So there's still a lot of resistance to overcome, both on the person getting service and also on the service delivery side. But there are lots of benefits to assuming you're going to have and then building the capability to do a hybrid model. It's unlikely that you're never gonna need to have physical office space, but if you have someone who's coming into a session physically once a month and 3 times a month are having their sessions remotely, then you can save up all of their paperwork and do it when they get to the office. That's just one silly example of where the hybrid model has a benefit. But the relationship building component of it, for any of you on the phone who have a background in family therapy, when I was a young family therapist and I was being trained, my supervision was based on the premise that in the first session, my job was to engage the family, instill hope, and have them come back for my second session. And that was when treatment could start. So that construct of engaging, that construct of having the family feel comfortable, having the family feel confident that I was able to help them, having the family feel like they could be helped, that this wasn't the worst case I'd ever seen. All of those engagement components, and then the whole process of working through individual family members' resistance, I just don't know how I could have done that remotely. I think that's a very, very difficult clinical ask. So I can see where you create a therapeutic relationship in person and then move to hybrid. And I can definitely see where you can begin to offer more non-traditional services. Think about like an E&M code, an evaluation and management CPT code that basically is a service for a person you already know who's having completely uncomplicated problems, right? I can check in with them for 15 minutes and meet the test of that CPT code. I don't have to have them be in a 50-minute session if there's no clinical indication for it. So let's go through very quickly the steps that one organization did to create a hybrid telehealth program. And by the way, full disclosure, nobody is doing hybrid right now because everyone is still basically working remotely. So, during the pandemic, there was very little resistance from the people who needed care to participate in a telehealth appointment. And so for the most part, telehealth was related to people who you already had a relationship with, right? It was, an emergency happened from day 1 to day 2, basically the country shut down. So it was a lifeline for people who were already getting services. And at first, everyone was very happy with it. People were more timely to their appointments. There were fewer no-shows. There was, very little resistance from the consumer community about being involved. But despite the availability of those services, the pandemic has been a behavioral health disaster. This was from an article in the Pittsburgh Post-Gazette, and the reference is in the notes, so you'll see it. But the unmet need that's happened during the pandemic, and the need that we can't meet, and the increase in incidence of drug and alcohol use, of people who report symptoms of depression and anxiety, it just overwhelmed all of these virtual services. And in terms of the in-person services, the demand has outpaced availability for psychiatric beds and for some drug and alcohol beds as well. So we can expect that over the next, I'd say, 2 years to 5 years post-pandemic, we're going to be digging out from the psychological, psychiatric, addictions harm that was done to people's mental health during this pandemic. And that doesn't include all the children and all of the educational needs. So one of the components of this system that was created was that the organization spent a lot of time thinking about marketing. It's if you look at all of the Therapist on Demand and Talkspace, they're marketing to a demographic that's not necessarily the community mental health bread and butter kinds of consumers. And so this organization really went out of its way to try to normalize the construct of reaching out and asking for help. Again, right now, everything is still remote, but their model is that at some point during the first few weeks of service, there's going to be a face-to-face engagement interaction, at which point the person receiving services is going to get to be, to be empowered to choose their most interested, their most interesting vector for getting their services. And so people will say, well, I really don't want to come in person any more than once every 2 or 3 months, but I'm happy to see you once a week if we could do it electronically. Or I hate electronic stuff. I'm going to, I want to come in every week. And so it's making the services accessible, eliminating the barriers to getting into care, and then really importantly, making sure that no matter what your socioeconomic status is, you have access that other people have. And so, this kind of health disparity and inequality problem has the potential to get much, much worse if the mechanism for services assumes everyone is sitting in a warm home with high-speed internet and an expensive laptop in front of them. Because that is just not reality for many, many, many of our clients and our potential clients. So this, this marketing model that this organization did really was associated with trying to assure that the marketing was equitable, right? So people of color, Black people who were non-native speakers. It's really important to have that face on your front door because you want to be as welcoming as possible. You want to open up that door as widely as possible. And then, really to think about that telehealth services is only one tool, and it's not the solution, it's just a tool. And so if we can name the problem, let's say we need to improve access. We need to get more people to come back for session 2. We need to engage more, non-native English speaking clients. We need to engage more clients who live in poverty. Whatever it is that we are stating our problem, then we can think about how can telehealth be one of the tools we use to try to improve things. And again, this organization was a drug and alcohol serving organization and really wanted to focus on the increase of people who were using drugs, illegal drugs, during this time. And so focused a lot of their conversations on what does that front door look like? And if you have all kind of wealthy looking white people, you're not really creating that mechanism. But if you have all Black people on your website, then it looks like you're saying only Black people have drug addiction problems. So, this whole construct of marketing really becomes an issue that I'm not sure we've ever gone through that much in behavioral health. But as we're moving to something that's more virtual, where that web landing page really tells a story, we have to think about those things. And again, depending on your problem. So if you need to improve access, you can get quicker intake sessions. If you need to increase access to prescribers, one person with a prescription pad sitting in front of a computer can see many people over the course of a day. And that's actually easier than having everyone walked through to that person's office. So the use cases we just talked about, telehealth services are a very practical way to expand access. Think about offering individualized treatment models to people in jails, prisons, nursing homes in a way that's just not practical to get people into those settings. And then increasing access to evidence-based treatment. So a lot of the fidelity measures that were done by recording sessions and then having people who really knew the program checking to see was that therapist, using the exact evidence-based model for practice. And so when you think about something like that, you could expand access to evidence-based practices if you could think about how to partner with specialty providers, with the fidelity-based organizations themselves. So I am almost to my summary. I want to stop and just see if anybody has any comments or questions. We're almost out of time. I want to make sure Christy has some time for some announcements at the end. But let me stop and check in.
Thanks, Sharon. Looks like no one at this time has put forth any questions or comments.
Okay.
So I think you're good. Oh, wait, we just actually, thank you, Victoria. That was very sweet of you. She says, this has been very interesting.
Oh, well, good. That's nice. Thank you, Victoria. So let me show you what I have in the summary, because again, this is for the slides for you to take with you. This is just the summary, right? We have to make sure telehealth doesn't become another barrier to care based on race, income, disease burden. We have to make sure that if we open up the store, we have a way for everybody to get in the door and not just people who already have a lot of, excuse me, I'm going to cough. Not just for people who already have a lot of resources. We really need to think about, we don't want to perpetuate or reinforce the two-tiered or three-tiered model of services that we have now. But there's so many ways to think about using telehealth to solve some big problems in the behavioral health marketplace. There's so many ways we can extend services, that we could open our door wider, that we could be available to more people. And so I really hope that this hybrid model of telehealth is a fixture in the future, and that we're all thinking about how to use this really interesting tool in our environment. The last set of slides is a summary. I think it's 5 or 6 slides. It's just a kind of regulatory overview. It's almost like a checklist that you could use if you're thinking about, how do I keep my telehealth service working in the future once the pandemic is over? We do not know how the states and the feds are going to try to pull back on some of the regulatory loosening that happened during the pandemic. Not clear at all exactly what the feds want to do. There are some states that have said they want to keep everything open, and there are other states that have said, nope, we're not going to keep this open. So, we have to be ready for all of it. But I put together this kind of checklist of things to be addressed if you're trying to develop a program that's sustainable. So check who's paying for what, making sure you understand licensing requirements, what's your service mix, what's the scope of practices, how are you going to privilege people, what kind of training do they need, how are you tracking success, re-engineering all of your operational workflows, how do people check in, how do they sign consents, what happens if someone no-shows, if a clinician is distributed, how are they going to get IT support, and then upping your customer service game. This really is related to that, opening the front door wider. All of your medical records rules, what is your training protocols, how do you ensure security and privacy of your data, what kind of marketing communications plan are you thinking about, and with that, that is the end of my presentation. So I'm going to turn it over to Christy to talk about some of the things that Open Minds is offering in the near future.
Fantastic. Thank you so much, Sharon. And again, for everyone that was here today, we know that this recording is going to be up on our website. That's awesome. All right, what is around the corner with Open Minds? So as an elite member, please remember that you have an all-access pass to our institute. So what you're seeing up on your screen is our next institute, the Technology and Analytics Institute. If you'll see, it's just around the corner. I know when we flip over the calendar, literally, right, for those of us who still use calendars, March is literally around the corner. So in just a couple of weeks, we have a completely virtual institute. If you happen to be or want to travel to the Las Vegas area, we'll have a couple of evenings with some on-site networking, but just know that the delivery of this institute will be 100% virtual. You can see on the left-hand side our keynote speakers. We've got Kathleen coming in to talk about the future of artificial intelligence. We've got Lisa speaking to digital therapeutics for behavioral health. And of course, a closing keynote by Monica Oss, our CEO here at Open Minds, forecasting the future of behavioral healthcare shaped by technology. And know too that even before we start the Institute, which actually kicks off March 10th, we open on the 9th with 2 seminars as well as a summit. So you can see there on the right-hand side our 2 seminars that we're offering. These are led by our amazing senior associates at Open Minds. We've got Paul and Joe doing that. And then a summit, which is really almost an all-day experience. And we're going to talk about nonprofit mergers, acquisitions, and affiliations. So that's it for the Institute. And one other thing, next week we have a really, really interesting presentation coming up. It's an executive web forum. And Corey, I'm wondering if you can actually, Corey's our producer today, just allow me to share my screen. Excellent. And I'm going to move it over. I don't know if it's showing. Sharon, are you seeing the webinar right now on the screen?
Yes.
Awesome. So next week, Rob is going to be here at 1 o'clock, same time, you guys. Why don't you have online scheduling and other questions that diminish your competitive advantage? So this is our website. You're probably all familiar with it because that's how you registered for today's. But again, this is another compelling, interesting session to come together. What you're seeing now is the brief description, but it is about a digital strategy. And this will be interactive as well. And look at all the different topics he's going to touch on, from online scheduling to Google My Business to analytics, social media presence. It is jam-packed. So that's next week, 1 o'clock this time. Wanted you to be aware of it. So Sharon, again, thank you. Thank you for our elite members who came on the session today. This recording will go up tomorrow. And Corey, thank you for producing this executive web forum this week.
Thank you, everybody.